Reproductive anatomy, gonadal drainage. All right, so for gonadal drainage, we have to first understand venous drainage, and then we'll go on to lymphatic drainage. First off, for venous drainage, the left ovary or testes will drain into the left gonadal vein, and then they must drain into the left renal vein before they get into the IVC. And that's different from the right side because the IVC is closer to the right side, so that means the right ovary and testes just have to go from the right gonadal vein, and they drain directly into the IVC. Okay? And so, for instance, there's going to be a pathology later on that we're going to talk about. It's called varicocele. And varicocele is more common on the left side because of the longer distance that the blood must drain into in order to get to the IVC. All right? And that's the first and most important thing. Second most important thing is lymphatic drainage. And you're going to be shocked at how many questions you're going to get about lymphatic drainage. So you have to understand it and memorize it first and foremost, okay? Right off the bat, if you memorize it, you'll be good to go. So, lymphatic drainage for males. The testes is para-aortic, and the scrotum is superficial inguinal. All right, and that's it. That's the lymph drainage for males that you need to know. And it just so happens the lymph drainage for females is going to be relatively similar, all right? So the testes is our main reproductive organs for the males, okay? And they drain into the para-aortic lymphatics. Well, the main reproductive organs of the females is the ovaries, and guess what? They drain also into the para-aortic, all right? And then as we move further up, the vulva, we'll start with the ovaries. The ovaries is the para-aortic. Then we'll start at the uterus. So the uterus is going to drain into the external iliac. And as we work our way down to the cervix is going to drain into the internal iliac. Keep on moving further down. The proximal vagina also drains into the internal iliac, but the distal vagina drains into the inguinofemoral. Lastly, the vulva also drains into the inguinofemoral. All right? And if you think about the way that the body's organized, the anatomy of the body, specifically the arteries, it makes sense because the arteries are close to the lymphatics, and that's why those names are located there. So next to the uterus, we have the external iliac artery, and so that's why the external iliac lymphatic is going to drain the uterus. And then as you get closer to the more medial, you have the smaller cervix, right? Because the uterus takes up the whole space, but then it gets narrower towards the cervix. And so that will drain towards the more medial structure, the internal iliac, right? Same with the proximal vagina. It's going to drain into the internal iliac. And then the distal vagina is going to be even further down, and it's going to be near the inguinofemoral region. So that's why I'll drain into the inguinofemoral location as well as the vulva. All right? So keep these in mind. These are very, very important. They will ask you pretty much every single one. So lymphatic drainage for males is testes is para-aortic. The scrotum is superficial inguinal. The lymphatic drainage for females, we have the ovaries, which is para-aortic. Then uterus is external iliac. The cervix and the proximal vagina are internal iliac. The distal vagina, as well as the vulva, are inguinofemoral. All right? That's it. Straightforward. Moving on to the female reproductive anatomy. There's going to be a lot of ligaments that they're going to talk about, and it's kind of just going to completely rattle you. So the only ligaments that you need to care about are two. The infundibulopelvic ligament, also known as the suspensory ligament. All right? So don't get those confused. It's the same thing. And the infundibulopelvic ligament, or the suspensory ligament, they carry the ovarian vessels, all right? So all the vessels, the artery and the veins that are going to be going to give blood supply to the ovaries, they are carried by the infundibulopelvic ligament or the suspensory ligament, same thing, all right? Now, this is cut off during ovarian torsion. So we're going to talk about a specific thing known as adnexal torsion or ovarian torsion, and it's just a pathology where the ovary twists around itself, all right? And that twisting of the ovary and the fallopian tube is around the infundibulopelvic ligament. And it's very important because it cuts off the blood supply to the ovary because the ovarian vessels are within that infundibulopelvic ligament, which is what's being rotated around in adnexal torsion or ovarian torsion. Another pathology associated with infundibulopelvic ligament, which they want you to know, is that during an oophorectomy, which is essentially the operation that takes out ovaries, and that might be used, in any case, like when a patient might have cancer and they're trying to remove the ovaries, right? So during an oophorectomy, when they remove the ovaries, ligation of the infundibulopelvic ligament is important, but it risks damaging the ureter because the ureter courses near not only the infundibulopelvic ligament, but also the next ligament that we're going to talk about. So be careful of any type of surgery that involves an oophorectomy. You can risk nicking the ureter and you can cause renal issues, okay? That's something that they would love to ask you. The next ligament and the last ligament that they care about is the cardinal ligament. The cardinal ligament carries the uterine vessels. All right. And so with the uterine vessels, we have the uterine artery and the uterine vein, right? So once again, during hysterectomy, a patient's at risk of a ureter being damaged due to the fact that next to the location, it's right next to that location of the cardinal ligament. All right. So be aware of those two ligaments. Very easy and straightforward. Both the infundibulopelvic ligament and the cardinal ligament, they carry the ovarian vessels and the uterine vessels, respectively. And the infundibulopelvic ligament is also known as the suspensory ligament of the ovary. And cardinal ligament has just no other name. It just carries the uterine vessels. But they both carry an increased risk of damaging the ureter when they go in to do an oophorectomy or a hysterectomy because of the proximity of the ureter. All right. Next, I'm just going to be talking about adnexal torsion because we already touched on it a little bit. For adnexal torsion, once again, it's just the twisting of the ovary and the fallopian tube around that suspensory ligament or around that infundibulopelvic ligament. Same thing. All right. And so that cuts off blood supply to the ovary because that's what's carrying your ovarian vessels. All right. And so what's going to happen is you're going to get potential necrosis later on if you're not going to resupply it. And the presentation of the female is the most important thing because in a vignette, it's very hard to tell what's going on and if it's like an adnexal torsion or if it's another pathology because all these pathologies present with like severe pain and things like that. So if the vignette says like sudden, one-sided, right? Because it'd be very odd for both of the ovaries to torse, right? So sudden, one-sided, intense pain with nausea and vomiting is indicative of adnexal torsion, all right? And another hint that they can give you in the vignette is that if there's an ovarian mass that's palpated that's greater than or equal to 5 centimeters. The reason behind that is that if there is a mass, ovarian mass that's greater than 5 centimeters, it will make the ovary heavy. And let's say it's at the top. That 5 centimeter or greater mass can make that ovary top heavy and it will flip it around, causing that torsion. So adnexal torsion or ovarian torsion is actually associated with ovarian masses greater than 5 centimeters. So if you see anything that says, they have a history of an adnexal mass, which is like 6 centimeters, and then they come in randomly with sudden onset, one-sided intense pain with nausea and vomiting, start thinking about adnexal torsion because they're giving you a little hint with the greater than 5 centimeter adnexal mass. All right? So that's an important pathology that they like to differentiate between other pathologies, which we'll talk about later. Lastly, I'll talk about pelvic organ prolapse. For pelvic organ prolapse, all this is just herniation of the pelvic organs, right, beyond the vaginal walls. And usually it's due to pudendal nerve injury, okay? Pudendal nerve injury is going to be the leading cause of prolapse. And a lot of the time they like to ask like why that occurs. Why is there pudendal nerve injury? And females during pregnancy, they're in this position that leads to the compression of the pudendal nerve consistently over a long period of time throughout labor. And so as you're done with labor, you've essentially pretty much caused ischemia to the pudendal nerve and caused damage or injury to it, and that can potentially lead to prolapse. All right? That's all that I wanted to cover. Actually, sorry, I'm going to cover one last thing for female anatomy. The last thing I wanted to cover was female reproductive epithelial histology. All right? They like to ask about histology, and the only thing that they really would like to ask about are two things. From the vulva all the way to the ectocervix, you're going to have stratified squamous epithelium. The reason behind that is because you want to protect the outside layer of our bodies. Whenever we're at the outside layer of our bodies, we have stratified squamous epithelium because it's multiple cells, right? A very thick layer of cells. Then you're going to reach the transformation zone, which has an increased risk of cervical cancer, okay? And this is where we do our pap smears. And the transformation zone is a very important junction because of that increased risk of cancer. So it goes from the ectocervix to the endocervix. And that means it's going to be stratified squamous epithelium from the ectocervix to the endocervix, which is simple columnar. And so whenever you see that transformation, it's a hot spot for cancer, all right? And remember that it's transforming from stratified squamous to simple columnar. The last thing that you need to know is that the ovary outer surface is made up of simple cuboidal epithelium. It's very rare to see any cuboidal, specifically simple cuboidal, throughout the body. We usually only see it in glands or in areas that we need to push things out. So think of the ovary trying to push out eggs during fertilization, right? And since it needs that ability, it will have a surface epithelium of simple cuboidal epithelium. All right. So if you ever see cuboidal, they're talking about the ovaries for female anatomy and histology. That's all for our female anatomy and histology. And the next video, we'll be talking about the male reproductive anatomy.